Hello and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Lyudmila Bazhenova from University of California, San Diego Moores Cancer Center, lead author on Therapy for Stage 4 Non-Small Cell Lung Cancer Without Driver Alterations, ASCO Living Guideline version 2026.3.1. Thank you for being here today, Dr. Bazhenova.
Thank you. It's my pleasure to be here.
And then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Bazhenova, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So to dive into the content that we're here today to talk about, Dr. Bazhenova, this living clinical practice guideline for systemic therapy for patients with stage 4 non-small cell lung cancer without driver alterations is updated on an ongoing basis. What prompted the latest update to these recommendations?
The Living ASCO guidelines are designed to keep pace with rapidly evolving evidence that changes the care of patients with lung cancer. As a committee, we regularly review the published literature on specific topics, and then we determine whether new data warrant changes to existing recommendation. In this recently published update, we evaluated new evidence related to the treatment of patients with metastatic lung cancer without driver alterations.
Great. Thank you for that context. So then based off this regular review of the evidence, what updated evidence did the panel identify on first-line treatment options for patients with non-squamous cell carcinoma, good performance status, and any PD-L1 expression? And how did this impact the recommendations of the guideline?
For this update, we identified 3 manuscripts that met our criteria and were included in our review. One manuscript was specific for a squamous cell carcinoma, and 2 included either all-comers non-small cell lung cancer or non-squamous non-small cell lung cancer. So if we go to discuss what evidence we reviewed for non-squamous non-small cell lung cancer, so number 1 is a trial called POD1IM-304. So POD1IM-304 was a randomized phase 3 trial comparing platinum doublet chemotherapy alone versus platinum doublet chemotherapy plus retifanlimab, which is a PD-1 inhibitor, consistent with prior data that supports the evidence of adding immunotherapy to chemotherapy in newly diagnosed lung cancer. This study also demonstrated improvement in both progression-free survival and overall survival, as we would have expected, because we now have a fairly robust set of clinical trials proving that addition of immunotherapy to chemotherapy outperforms chemotherapy alone. Retifanlimab is approved by the US FDA for other oncology indications, not for lung cancer. And we really don't anticipate that this regimen will be used for lung cancer because we have other options which have been FDA approved a while ago. We thought that it was important to include that evidence because it confirms the class effect of PD-1 inhibitors in this setting. And I think the only way one would consider using retifanlimab is in areas of difficult access, or if there is a cost will start playing a role in the selection. The second study that I think would be important to discuss for a non-squamous group is the BAP BRAIN. So BAP BRAIN was a phase 3 clinical trial which enrolled primarily in China, but it asked a very interesting question. So it took patients with active brain metastasis and then randomized patients to platinum-based chemotherapy alone or platinum-based chemotherapy plus bevacizumab. The trial enrolled before we changed our standard of care, which is now for the non-driver alteration is chemotherapy plus immunotherapy. But I think this study gives an additional evidence on efficacy of bevacizumab in addition to chemo for patients who are, for example, not eligible for immunotherapy. So for the BAP brain, they allowed patients who have untreated brain metastasis, but they had to be asymptomatic and they had to have a minimum of 3 brain metastases. And the primary endpoint was intracranial progression-free survival. They also looked at intracranial overall response rate and overall survival. The study was positive. It showed improvement in intracranial progression-free survival, as well as improvement in overall response rate and also longer overall survival, longer median overall survival. The study did not change our recommendation because our first-line standard of care for patients without driver alteration is actually immunotherapy-based treatment. But I think, as I mentioned before, this study is very important for 2 reasons. Number one is if you have a patient with brain metastasis who are not eligible for immunotherapy, I think that gives you enough evidence to add bevacizumab to platinum doublet. And the second, I think we are struggling to include patients with active brain metastasis in our trials. And every single time we see a trial that specifically asks the question on systemic management for patients with brain metastasis, I think it's important to highlight the study. We have evidence that we reviewed in the prior guidelines from a single-arm phase 2 atezabrain trial, which used atezolizumab in combination with carbapemetrexate for patients with untreated asymptomatic brain metastasis. It was a very small study. Only 40 patients, was single arm, but it appeared that chemotherapy plus immunotherapy has an intracranial response rate of 42%. And in the BAP brain, the response rate was 69%. So cross-trial comparisons. But again, for the patients who are eligible to immunotherapy, my first treatment option, of course, would be platinum doublet plus immunotherapy for patients with brain mets, assuming radiation is not immediately needed. But again, for patients who are not eligible for immunotherapy, that gives you another treatment option.
Thank you for reviewing these 2 trials. So it sounds like first there was POD1IM-304, which actually impacted the recommendations and adds to the arsenal of treatment options, even if it may not be the one that clinicians turn to most frequently. And then BAP brain, that did not lead to a change in the recommendations, but provides some important context and puts the existing recommendations into perspective. You mentioned 3 total studies that met inclusion criteria for this latest update. So what was that additional trial that the panel reviewed that didn't lead to a recommendation change?
So the additional trial that we reviewed was Harmony 6, and this trial enrolled patients with squamous cell carcinoma. And we really do not have a lot of good options for patients with squamous cell carcinoma, and they tend to survive shorter amount of time compared to patients with non-squamous. So Harmony 6 was a randomized double-blind phase 3 trial, which compared ivonescimab, which is a PD-L1 VEGF bispecific antibody, and that was given in combination with platinum doublet. And control arm was platinum doublet plus tislelizumab, which is a PD-1 inhibitor. The trial enrolled primarily in China. Trial included patients with treatment-naive squamous cell carcinoma. The trial was positive. Ivonescimab significantly improved PFS compared to chemo IO. The benefit was seen regardless of PD-L1 status. One subset analysis to note is the benefit seems to be less pronounced in patients who were older than 65 years old. And at this point, this trial did not change our recommendation because it wasn't a global study. We have to be careful with studies recruiting in more of a homogeneous population. And we would like to see a global study results, which is already ongoing. We also felt that the short follow-up time is important here. It was only 10 months. And with a longer follow-up time, we really don't know what the results are going to be. And then there was some imbalance in the arm. There was a higher incidence of brain metastasis and never smokers in the control arm. And at this point, we are waiting for the global study called Harmony 3 to result. And then hopefully that will further clarify the role of ivonescimab in the first-line metastatic setting.
Absolutely. We'll wait for those additional results to inform whether this is a new option that can be added to the guideline as well. So then you've alluded to this throughout our conversation already, but what should clinicians know as they implement this updated living guideline, and how do these changes impact patients?
With the studies that we have reviewed, we added one more medication to first-line treatment options for driver alteration negative, and that was retifanlimab. In a way, it is one of the options available for those patients, and addition of retifanlimab does not really change the other medications that are already listed, like pembrolizumab or atezolizumab or durvalumab. I think the reason we decided to include it is because it is FDA approved for some other indications, oncologic indications, and should there be a cost saving with retifanlimab or other reason to use it, you now have it in the guidelines with the data supporting its usage.
Understood. It's really important that the panel has reviewed this new evidence across all three of these studies, even when it hasn't resulted in a change to recommendations or even a significant change to recommendations. So then you've touched on this already with reference to Harmony 3, but what additional evidence is on the horizon for future updates to this living guideline?
So ASCO Annual Meeting is coming in June, and we are very excited about ASCO. And usually this meeting results in many simultaneous publications, and generally it is a very busy time for the guidelines committee members. And we have an update planned right after ASCO. So I say stay tuned.
Great. Well, we'll look forward to hearing what new research is presented and how that translates into impacts to the guideline recommendations. So I want to thank you so much for your work to rapidly and continuously update this guideline. And thank you for your time today, Dr. Bazhenova.
It's my pleasure.
And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/thoracic-cancer-guidelines. A companion podcast episode on the stage 4 non-small cell lung cancer with driver alterations living guideline is also available. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.